Good evening, everyone. I'll be presenting a case of transient hemianopia, which is a rare manifestation of acute migraine. A 12-year-old female presented to our emergency department with complaints of headache for 3 days, which is postmenstrual in onset, severe unilateral pulsating and associated with vomiting, and it was triggered by sleeplessness in the previous night. Her ocular examination was essentially very normal, an uncorrected visual acuity of 6/6 in both eyes with near vision and color vision normal, equally reactive pupils, and a full extraocular movement, and an unremarkable anterior segment and posterior segment findings. In-office confrontation examination revealed a left homonymous hemianopia, and the patient also reported not seeing right side of the Snellen's chart while recording her distance vision. And this is a standard perimetry Humphrey field analysis Sita 24-2 done on the patient immediately after she reported, after we found out that the patient had left homonymous hemianopia, which shows left homonymous hemianopia on Humphrey fields. Migraine is essentially a diagnosis of exclusion, and to exclude other treatable lesions, we did CT brain and MRI brain, which was within normal limits, and our blood parameters with normal, and we arrived at the diagnosis of migraine with homonymous hemianopia. And the patient was treated with neurologist consult with cerebroselective calcium channel blockers like flunarizine, oral propranolol, and oral NSAIDs. And this was her visual field examination done around 10 days after her presentation. The patient was periodically reviewed in our ophthalmology clinic, and she reported progressive improvement in the visual field defect starting around the 6th day of after presentation, and it nearly cleared at the 10th day. So we did a repeat HFA, and repeat HFA shows no visual field defect, no demonstrable visual field defect. And the possible differentials for this patient would have been retinal migraine, occipital lobe seizures, subarachnoid hemorrhage, and transient ischemic attack. Retinal migraine are essentially uniocular in nature, which is not present in our patient, and occipital lobe seizures most prominently present with centrally located visual field defects, and again is not ruled out in our patient. And normal neuroimaging and absence of risk factors rules out subarachnoid hemorrhage and transient ischemic attack in our patient. Visual phenomenon associated with migraine can be either negative or positive, like scotomas, photopsias, and scintillating scotomas. There are two theories which have been proposed for the cause of visual field defects in migraine. One is a vascular theory in which the initial vasoconstriction phase causes a scotoma, and progressive and the following vasodilatation causes the headache, and the pain is due to the stretching of trigeminal nerve fibers associated with pial, dural, and meningeal vessels. And one more theory is the cortical spreading depression theory, in which the altered cellular excitability is somehow related to the spreading of depolarization waves along the cerebral areas, which causes a generalized cerebral oligemia, and in experimental models have been proposed to cause release of matrix metanoproteinase 9 and disruption of blood-brain barrier. And migraine-related cerebral ischemia of occipital lobe is potentially the cause of visual field defect in our patient, and the most common vessel being affected is a posterior cerebral artery, in fact. This case report emphasizes the need for visual field testing as a baseline evaluation in patient presenting with headache. It is thus possible that some of the dysfunction measured the day after a migraine can be explained due to effects of fatigue or poor concentration after migraine. And even if migraine visual field defects have no long-term cumulative significance, knowing the likelihood of this to alter the visual field performance is essential for accurate parametric interpretation in the management of other eye disease which mimics in migraineurs. And the future translational research or the points to ponder in such a case will be the presence of visual field defect predictive of a future eye disease? Or does the migraine even themselves affect visual processing, or there are underlying metabolic or neurological differences in some migraineurs that predispose them to both migraine and to visual field defects? These are my references, and thank you.